Okay, thanks. That was a great example of how we can work with some of our young people to develop a script that really makes sense to them to understand some more about the sort of genomic field. Okay, thank you very much. We're moving on to our next session now, which is a research hospital session focused on applied child health informatics. And Thomas mentioned this is the new theme we're hoping to have in the next BRC that we've bid for. So I'm handing over now to Dr. Pia Hardelid to explain more.
Thank you so much, Laura, and good afternoon, everyone. My name is Pia Hardelid, and I'm Associate Professor of Epidemiology at the Institute of Child Health. And in this session, we are going to talk about the Applied Child Health Informatics theme that, as Laura said, we are hoping to take forward in the next BRC. So in the interest of time, we're going to go straight to the first speaker. So I'm delighted to be able to present Professor Neil Sibir, who is the lead for the ACHI theme, and I am the deputy lead. So Neil, take it away.
Yep, thanks very much, Pia. And this is really going to be a bit different to some of the talks you've had so far, because obviously this is a completely new theme. So what I really want to talk about is how the theme came about, what we're building on, and what we're planning on doing. So just to put this in context, everyone will be aware from their daily life of the impact of data now. But actually, in the last 5 years, this has become a massive area for the NHS. It's part of the life sciences industry strategy. It's part of the NHS long-term plan. It's a major part of what NIHR are now focusing on. And AI and data is becoming important. So there's a sort of a national priority. In addition, as I'm sure you're all aware, we've gone from having hundreds and hundreds of different clinical systems, being the bottom 10% of digital maturity, to now being a HIMSS level 7 organization with a dedicated data platform. So we've now got the infrastructure in place to be able to make use of our clinical data. And in addition to that, there are lots of things happening from the UCL ICH side in terms of teaching, training, data science, etc. So really, the one of the drivers for this theme is to say, how do we leverage all of these things? How do we bring them together, but in an applied way, so we can actually make a difference for patients? And that's really how the theme sort of came together. And there is also a developing specialty, if you like, of clinical informatics, which is all of the issues around data and digital, but applied to real world patient care. And that could be digital devices, it could be apps, it could be machine learning algorithms, etc. And there are lots of things that are already starting on this that we're also feeding into. So for example, we're part of a national program for digital pathology. We're part of the UCL healthcare enabled AI CDT. We're a part of HDR UK, etc., etc. So we're really building on this background. So although it's a new theme, there's a huge amount of work that's already been carried out that we're building upon. It's just it hasn't been really within the BRC before. So obviously the main BRC focus is on infrastructure and is around this experimental medicines. How do you bring things sort of first in man? And therefore there are several components that really make us unique in this space. So obviously the first is our patients and population. So this is the same as for the clinical side, but the data that we have is really unique. The second thing is that, as Thomas mentioned at the beginning, we're already doing quite a lot of work with our YPAG group and PPIE work around what do children and young people think about things like machine learning and artificial intelligence? Because nearly all of the work that's published so far is in adults, about what they think about whether their data should be used and how it should be used. And we're really keen to understand how children and young people feel. The other thing is that obviously we want to leverage this infrastructure we have and the complex data that we have. And really this runs across multiple of the themes. And I'll mention a couple of examples of how we're working with genomics. But the idea here is that we're building infrastructure that can benefit across all of the themes. And it's this focus on how you apply that I think is the different thing. So being a bit more specific, one of the areas that we are looking to work to develop in assuming we get funded for the new theme is in training and capacity building. One is around the infrastructure, and particularly something called FAIR, which I'll come on to in a moment. So how do we do better data management? How do we use our real world data to make decisions for patients? So this informatics consultation idea. And you'll hear in a moment from Maria and Pia's side around how we're using complex data sets for life course and linkage. So we're in the fortunate position that we have this infrastructure now with an EPR system and a dedicated digital research platform. And this is a very common thing that you're now going to start to see in almost all of your grant applications, which is this concept of a trusted research environment. The old idea that people would collect data on their laptops, they keep it themselves, they use it, and then analyze it themselves is really not acceptable anymore for lots and lots of funders. With the idea being you have a platform that manages the data, that's fully auditable, that's secure, that's backed up, and it allows federated analysis and collaboration. And we're the first NHS organization in the country to have a DRE environment sitting within the NHS space. And what that allows you to do is basically fully de-identify, control, audit your data, but it allows us to harmonize and provision that data in ways we really couldn't do before. And this concept of how do you make data findable, accessible, interoperable, and reusable is called FAIR. And it is a major thing now for many funders. And it's been estimated, for example, that across the EU, just making having better data standards and data management will save about 4.5 billion in research costs. So this is a major focus for NIHR and for us. And the other thing is that lots of companies now, this is a paper this year from Google, that have shown that if you're trying to develop an AI tool, nearly all of the problems you get down the line are due to issues with the data itself, either the data management, collection, labeling, etc. So this is a really fundamental thing for us. And the idea of the informatics theme is to work across with other groups. So one example is we're already working with the genomics theme about how there's the work you've already heard already from the bioinformatics side, but in terms of the reports, clinical reports, these still tend to come as PDFs. So how do you get the structured information out of these reports in a way that allows you to do clinical decision support and improve research? Other things, of course, are then how do you build not just the data we have, but the new data types like devices into clinical pathways. And this is another major area, and I'll just touch on this at the end. And then the last piece of the puzzle really that goes together in terms of our USPs is around all of the existing expertise and work in the PPP theme. Now, obviously, some of that is not eligible for the BRC directly, but many of the things and insights we can get from this kind of data analysis, we can use both for policy and managing future patients. And there are a wide range of essentially either unique or nearly unique data sets that we have. And one of the most exciting things for me is this idea, a lot of the work that Pia, Ruth, and others are leading on of linking data sets together. So imagine that you developed a gene therapy or a new drug, and not only do we know what happens from a medical perspective in those patients, but imagine if you could understand their school performance, their social, what happens to them in their life, all of the other things. So there's some significant work around how we might better link these data sets together. And the final part is we're obviously looking at technology and the new data that is coming from technology as well. And we're linking up with Sheffield Children's Hospital. Sheffield lead the NIHR Children and Young People MedTech Cooperative, which is around devices. And the idea is that we're going to work closely with them in the new BRC and with other partners as well, where essentially the expertise of device development can be done in Sheffield, and the expertise around the data and informatics part can be done with our platform. And again, apart from the devices themselves, a major component of this is going to be all around the things of what do children and young people think, and PPIE work around not just the data, but devices, technology, AI, etc. So I'm going to finish there. I'm going to hand over back to Pia, and you'll hear more about a specific example from some work that's been done already on an existing data set.
Brilliant. Thank you so much, Neil. Now, as Neil said, we're going to show you an example from my colleague from Institute of Child Health, Dr. Maria Pepper, who is funded by the BRC. She is a data scientist and senior research fellow, and she's going to talk about how we can use administrative data, such as routinely collected national hospital data, to look at health outcomes for children with rare diseases. And Maria, I believe, has recorded her presentation, so please may somebody put the recording on. Thank you.
Hi everyone, thanks for having me here today to give an overview of the work we've been doing on rare disease cohorts using administrative data. Progress in rare disease research is complicated by the variability or heterogeneity, as we sometimes call it, between patients with the same condition. And that heterogeneity can take many forms. It could be heterogeneity in the causes of the disease, in the age at presentation or diagnosis, or in severity or and progression. But we can tackle that challenge of heterogeneity using administrative data. And we're very fortunate in England to have excellent administrative hospital data that covers the whole country. These data go back 20 years and they capture all hospital contacts across NHS England hospitals. And that means we can start follow-up of all children born in England from birth and look at their health data into early adulthood. So what that means is we have the numbers and the long follow-up necessary to identify subtypes of rare diseases and perform high-resolution studies. And what's more is we can enrich the administrative data we have by linking in additional data held in registries by specialist centres like GOSH, so things like genomic data or even patient-reported quality of life data, which are very important and perhaps only collected at specialist centres. And we can also link to other administrative data such as GP, education, and social care data. But it's not enough to know that data is available. We have to have the expertise and the access to it. But thankfully that expertise and access is available within GOSH BRC and more widely within UCL. So to demonstrate how we can examine heterogeneity, we identified all infants born in England from 2002 onwards with a congenital diaphragmatic hernia, CDH, which is a very rare condition. And we grouped those into two subtypes, those that had isolated CDH and those that had CDH as well as an additional congenital anomaly. And we call those cases complex CDH. So if you look at the mortality curve on the left, you can see we identified over 700 infants in each subtype. And so those large numbers gave us a lot of power for analysis. And we found that those with complex CDH had a greater risk of death than those with isolated CDH in the first year of life, with most of the deaths occurring at the time of birth. And although it's not shown here, we were able to extend follow-up to 10 years and found that actually after the first year of life there are very few additional deaths. So then in the second graph on the right, we drill down even further into the subtypes, and we identified cases of complex CDH that had severe or non-severe cardiac anomalies, and we compared those to isolated CDH. And we found that those with non-severe cardiac anomalies had a similar prognosis to isolated CDH infants, whereas those with a severe cardiac anomaly had the highest mortality of the three groups. So none of this is necessarily surprising to clinicians who work on CDH, but what this work does is demonstrate that we can identify subtypes in good numbers, we can be confident they're valid, we can go on to address further knowledge gaps, and we can use that information to identify areas where we can improve clinical practice, but also areas where we can provide additional information to affected families. Where do we go from here? Well, we can apply this to other rare conditions, of course, and describe subtype phenotypes and differences in prognosis. And we can also look at how risk factors for a particular condition vary by subtype. We can also start examining the well-being of affected children outside of just their health outcomes. So in our group, we have linkage to education and social care data, which we'll be using to examine how these children are supported at school and the interplay between health and education outcomes. Thank you, and happy to take any questions.
Great, thank you. So I think we have time for some questions now, Laura, is that right?
Yes, we have a couple of questions, and I think they're probably both directed at Neil, if you want to return to us, Neil. Great, thank you. So the first question, how long do you think it will be before patients are able to be treated in a personalised manner based on sort of real-time data?
So that's absolutely the vision. And I would envisage that we would have a proof of concept of how you may be able to do that quite quickly now that we have access to the infrastructure to do it. There is an interesting a whole lot of work then that needs to be done around things like governance and regulation, because at the moment the way we treat patients is we say, here's a paper from Brazil and we're going to treat you like this because that's what this study said. Whereas in fact, we have treated 500 previous patients like you at GOSH, but we don't use any of that data. If we did use that data and it's slightly different to what the publication says, is it okay to make management decisions? So at the moment, that's definitely the aim. At the moment, we're very much focused on the technical part of making it possible and feasible. If it is possible and feasible, which we know it will be, there is then a whole lot of work that needs to be done over the coming years around how should you do this, and what would people think about it, and what do patients want from that information, what do clinicians want, and all those kind of things. So it's a super interesting area.
And there's a second question, which is, how is the DRE platform helping researchers, I suppose, providing added value to researchers? And what key skills do they need to be able to use the DRE?
Yeah, so the key thing is that the DRE now, because we have a lot of the legacy data, so we have the structured, so at the moment we don't have data extracted from free text, but that's to come this year. But at the moment we have over 500 million records that are basically digitized within the DRE. So that means that it's possible now to provision data around observations, medications, demographics, etc., for research studies, literally within minutes that would previously have taken a research fellow 9 months to get that data. In terms of the researcher skills, the skills are to be able to know what you want and to ask for the data, and then know how to analyze the data. Because we sometimes get researchers coming and they say, oh, can you give me all the lab tests for these patients? And we say, do you really want all the lab tests? They say, yeah, I want all the lab tests, thinking there'll be a few hundred, and there'll be thousands and thousands of lab tests. And that's probably not what they actually wanted. So there is a little bit of a skill in that. And I would encourage anyone to, right at an early stage, speak to the DRE team.
Great. So I think Laura, those are all the questions. Great. So thank you so much, Maria and Neil, for giving us a flavour of the Applied Child Health Informatics theme today. We're very excited about it, and I hope you are too. And let's hope it goes forward. So thank you very much. Over to you, Laura.
Thank you very much, Pia. We're moving to a brief 5-minute break now. Give everyone a chance to go and get a cup of tea. One quick reminder, we are going to close our image competition poll in 5 minutes. So if you haven't done so, go over to Slido and vote. I think we've had 86 people vote on their favourite image so far. So, and there is, at the moment, there's a clear favourite, but it's interesting. It could still be swung. So we'll be back in 5 minutes to start with our next session. Thank you.